Good morning, everyone. I'm excited to get this day kicked off with our live poster session. We have three great researchers that are going to be presenting their work based on some of the posters you saw out in the hall. We're going to start with Jen Corcoran. Jen is presenting on her poster, which was titled Palliative Care Helps with the Parkinson's Puzzle, a Qualitative Study of Patients and Family. Is there a up here? Sorry, just before I. All good. Okay, All right, good morning. I'm Jen Corcoran, part of the University of Rochester contingent at this meeting. And this morning, I have the pleasure of presenting on behalf of the whole group listed up here our conference abstract titled Palliative Care Helps with the Parkinson's Puzzle, a Qualitative Study of Patients and Family. Before talking about the research itself, I just want to acknowledge some really key people without whom this wouldn't have happened, including our colleagues and members of the Parkinson's Foundation Clinical Affairs team, the clinicians and palliative care champions at the many Parkinson's Foundation Centers of Excellence who participated in the study, the people with Parkinson's disease and care partners who participated, and the Patient and Care Partner Advisory Council, who are really key collaborators at all stages of the project. I don't think I have to tell this group necessarily that people with Parkinson's disease and their families have a number of significant palliative care needs that have not traditionally been well addressed in typical models of care. And to address this, Dr. Kluger was the PI. We implemented a large 3-year dissemination and implementation project implementing team-based palliative care at Parkinson's Foundation Centers of Excellence. For the study, palliative care was operationalized with this 5 pillars model, which included systematic assessment and management of non-motor symptoms, systematic assessment and management and support for emotional and spiritual needs, systematic assessment of care partner needs and connection to resources and support for care partners, completion of annual advanced care planning, and when needed and appropriate, timely referrals to specialist palliative care and to hospice. So after that implementation piece of the project, the data that I'm presenting here today is a smaller qualitative piece of this larger study, where we sought to post-implementation understand the perceptions and experiences of people with Parkinson's disease and their care partners around receipt of core elements of palliative care, and to understand the care preferences of people with Parkinson's disease and care partners and what their suggestions would be to improve care in the future. We did this using a qualitative descriptive research design and conducted semi-structured interviews between April and May of 2023. We completed interviews with 19 people with Parkinson's and 20 care partners, and data were collected until evidence of saturation or repetition of key themes in the interviews was achieved. And after completion of the interviews, we coded all of the data, analyzed it, and developed the 4 key themes that I'll present here. Theme 1, non-motor symptom checklists provide a framework for discussions with providers. Many of the participants in this study felt that the use of these systematic non-motor symptom checklists at their Parkinson's clinic visits were helpful in really proactively identifying bothersome symptoms. Some even commented it was just helpful to see and learn what actually could be associated with Parkinson's disease if people weren't aware of some symptoms that could be related. And for some people too, it was they commented on symptom checklists being helpful in framing where they or their loved one were in sort of the roadmap of the disease. All of these names are pseudonyms, by the way. This is all de-identified. Helen, a person with Parkinson's disease, said, "It showed me that there is help available without having to bring it up myself," so commenting positively on that proactive nature of these checklists. Daniel, a care partner, commented about his wife's team, positively, that they're documenting all of their concerns, that they seemed very aware of where she was in the disease process based on her motor and her non-motor symptoms. Theme 2, team-based palliative care improves the quality of care. So these interviews were conducted with people with Parkinson's and care partners who got care in different centers of excellence using different models of care. some of whom are getting seen in interdisciplinary or multidisciplinary clinics. And the people who are getting this care reflected very positively on the experience in these interviews. Lisa, a person with Parkinson's, commented about the benefits of getting into a program where having clinicians with different backgrounds like psychiatry and neurology collaborate and evaluate her symptoms and help make sense of things was a really good thing. And I think Matthew, a care partner, sums it up very well, where he was talking about, here he's talking about his wife's first visit to establish care with like an interdisciplinary team and how they had this very extensive, very thorough team meeting with multiple team members, and says, we came away from that and said, this is the sort of medical care we're looking for. So just really summing up that this interdisciplinary or multidisciplinary approach is like an ideal model of care. Theme 3, lack of care coordination is a source of stress. So it seemed like for some people, almost the flip side of identifying non-motor symptoms is it can trigger referrals and build out the team, and that's good, but the care coordination in our healthcare system is a pain point for a lot of folks. Nancy, a person with Parkinson's disease, felt that her team was really comprehensive in asking her questions about her Parkinson's, but that they didn't really seem, that different members of the healthcare team addressing her symptoms weren't really collaborating, weren't really communicating, and just not functioning as a team. And Patricia, a care partner, commented, this was about her husband, he has 13 specialists, she's managing all of that, she's managing all of the medications, and what do people do if they don't have someone who can take on this very weighty role? Some other participants in the study who aren't directly quoted here felt that they were getting contradictory advice. Like one person mentioned a cardiologist feels that blood pressure should be lowered, and then their neurologist is really concerned about that because of the prevalence of orthostatic hypotension in Parkinson's disease, and that they were sort of going between these specialists trying to figure out what the right thing to do was without a lot of great communication. Theme 4, focused education on symptom management, medications, costs, and insurance are important. So some of these topics were really identified as pain points by some of the participants in this study. Richard, a person with Parkinson's, felt that there needed to be better proactive support and education for caregivers about what to expect. And Margaret, a care partner, felt that it would be really helpful to have some kind of a professional advocate to help them navigate systems of care that were difficult. Other pain points that on this related to the theme that came up would be people felt that they needed a lot more help early on knowing how to navigate health insurance systems and dealing with health insurance when their needs were mounting later and they needed more help and they needed more care, issues with how to afford medications, and some people also brought up issues with things like disability applications and feeling like they had needed earlier and more proactive guidance about when that would happen, how that process gets started. So in conclusion, people with Parkinson's and care partners clearly value a team-based approach to the care of their multiple complex Parkinson's symptoms, and in the future, clinical efforts and research is needed to improve care coordination and also develop more focused education for people with Parkinson's and care partners on these topics of importance to them. And I think we have a few minutes for questions. Someone in.
Now? Oh, we are on now. Oh, God. All right. This was amazing, and I was wondering if maybe in the future you can consider a grounded theory qualitative study on what is the process of implementing effective palliative care teams, because that could be a more in-depth study related to a specific qualitative methodology. And also, the word saturation is quite often used, but there's another word coming on the horizon. It's called informational power, related to getting enough participants in a study.
Yeah.
Thank you.
Thank you so much. Yeah.
It's not as stringent as saturation. Informational power is really coming out of Europe, the UK more, And what it is that it's based on the assessment of the researcher determining if enough, based on what they're seeing, it's determining if there is enough participants in a study. It's not just the numbers of seeing themes on and off, but it's more the determination of, well, we've discovered that this concept is fully researched, so now we have determined that it is. So it's different. It's informational power.
Thank you. I'm going to read up on that.
Thanks very much. I was wondering about the sort of, how do you find negative reporting? You know, when I'm sure people love this intervention and people who were willing to talk to you were probably only those who particularly loved it. And one idea was this, you know, too many cooks, the person, and I wasn't sure if that had anything to do with your intervention, because I don't know enough about your intervention, but does that add more cooks into this even?
Yeah, I think that would probably, I think that is hard to tease out from like from the interviews itself. Like, would they, if they had developed a certain symptom, I don't know, 5-10 years ago before this intervention, have gotten specialist referrals? I would guess, partly just from clinical experience, that yes, like identification of symptoms, like for example, urinary symptoms that some neurologists might not feel comfortable addressing, is going to trigger a referral, and then it's going to lead to mounting care coordination issues. So I would guess that the non-motor symptom checklist and symptom identification and the care coordination difficulties might be linked, but I think that's hard to tell from this study. But sort of like from clinical experience, I think they probably are linked. So I think maybe like another intervention in future would be, you know, better education for, say, movement disorders neurologists on, you know, management of urinary symptoms would be one, or other symptoms that often trigger specialty consults, because I think, you know, my experience, it's very variable between practitioners, like what they're comfortable doing, what they feel like is part of their practice. So some patients, if you're seeing someone who feels comfortable managing these symptoms, they might just get it all managed sort of in-house. And some patients may wind up with a lot of specialist referrals, and then the care coordination issues come up.
Thank you, Jen. If you have more questions for Jen, please find her during a break. We're going to go ahead and move to our next presentation. Joshua Davis is going to be presenting on his poster, Large Language Models for Scalable Tracking of Symptoms in Neuropalliative Care.
Can we get it on the little screen too? All right, thank you very much, everyone. My name is Josh Davis, and today I'll be presenting large language models for scalable tracking of symptoms in neuropalliative care. I have no disclosures to report. So before I go any farther, could anyone who has used ChatGPT either personally or clinically raise their hand? And so as you see, this is becoming more in vogue. And so, but for everyone, just to frame the conversation, how do large language models like ChatGPT work? So they work as next word predictors. So for example, if you first hear the sentence, my pet is tired, and then you hear the phrase, the cat is, the word sleeping would be very likely to hear next. It'd be a little bit less likely, but still possible to hear the word running. But my cat is chest does not really sound right. Similarly, in a clinical setting, patient has a heart attack followed by the phrase pain in the chest or pain in the abdomen would sound relatively appropriate, but pain in the sleeping would not. And so we can leverage this approach to say, based on information, then you can ask a question, and then the answer would be the next most likely word or words following it. And so this is a way that we can use large language models to extract information from clinical text. The objective of this project is, can a large language model identify symptoms documentation in the history of present illness section of clinical notes? So the way we did this is we took 421 clinical notes. They were then looked at for two symptoms of interest, headache and neuropathy. They were double coded, and we found 717 instances of these keywords. And then we had the human annotators label for if the symptom was affirmed or negated in the clinical text. We then wanted to compare a rule-based approach to a large language model to see the performance of replicating the human effort. The prompt that we used for the large language model was, is the symptom headache or neuropathy affirmed or negated? And for context, our rule-based approach was, for example, if you have the phrase, the patient denies headache, you could have a rule that says if the word denies happens within 5 words before the word headache, that would programmatically be marked as a negation. And so there's been prior work and publications on basically rule books to tell a computer how to tell if something's affirmed or negated. And this has a lot of benefits, but it's limited by how creative and how robust your rules are. And if there's differences in clinical documentation styles, these rules may not directly translate to your institution. So you wanted to see if a large language model could capture information a bit more flexibly. So what we found was that first, in the 717 excerpts that we had, for headache, there were 272 excerpts found. The symptom was affirmed in 155 excerpts and negated in 117. And for neuropathy, it was affirmed 392 times and negated 53 times. What we found was that ChatGPT, in this case GPT-4o, which is one of their newer flavors, if you will, had statistically significant increase in performance over a rule-based approach with a sensitivity and specificity of 98 and 95% respectively. And as you can see, the rule-based approach definitely works very well and has a lot of benefits, but for certain use cases where you want to have the highest quality data extraction from clinical notes or research projects, there could be a benefit for the added cost and complexity of using a large language model instead. So both modalities have different value. It just depends on the type of project one is working on. In conclusion, large language models show potential in accurately extracting symptoms from clinical notes and outperform traditional rule-based methods. I'd like to take a moment to acknowledge my colleagues Bridget Dureau, Zachary Tentor, Juan Manuel Gutierrez, John Rhee, and my mentor and PI, Dr. Lindvall. Thank you very much, and I'm happy to answer any questions.
Thank you. So large language models depend on information being out there for them to get. In this area, do you think that there is a way to get more information into large language models than currently exists today?
So I can't speak to the general state of all information on the internet, but in the clinical context, there is a massive amount of data that's currently left in unstructured free text from clinical notes, for example. And you can definitely use that information for large language models, for in this case, we're using it for extraction. Building a large language model in a clinical flavor, if you will, there has been work done with that, especially using the Mimic database out of Beth Israel. And people have tried to improve the performance for clinical use cases and make purpose-built large language models for the clinical domain. They sometimes work better, they sometimes work worse, given there's a new large language model every few weeks. And so researchers sometimes don't have the ability to move as fast as the big companies. So the most recent OpenAI models, like this one, would perform better than a clinically specific one that was built a year ago. So it's really a moving target.
Thank you.
Thank you very much for your talk. With this, apologies if this is a very entry-level question, but would this work in the reverse direction? Like you could look at patients' charts who were referred to neuropalliative care, have seen neuropalliative care, and then use the large language model to identify search terms, like certain keywords that trigger the referral?
You could definitely use a large language model for that. If you're looking for specific keywords of interest, there are other modalities that are very beneficial. For example, if you're doing research looking for keywords in documentation, the Linval lab has a software called Clinical Regex where you can literally create a list of keywords, load in the progress notes, and then it'll highlight every instance of those keywords, so then you can, for research purposes, annotate very quickly.
Thank you.
Thank you. I like the term entry level. My question is going to be similar, and will probably reflect my age as well. So can you expand a little bit on how this might help me, a clinician, or anybody in this room, with a specific patient, or with our panel of patients, or even our division or section with a whole group of patients?
Of course. So one way that this could be beneficial is with longitudinal symptom tracking. So say you have a patient and you want to see up until your first encounter, how have their symptoms progressed since the moment, say, they were diagnosed with the condition that you're being referred to about. And so then you can have some visualization of, say, headache, neuropathy, fatigue, and then you can see in those different symptom domains how they track from visit to visit and in the clinical documentation. So then you can say, 1 year ago, they only had headaches, but now they have headache, shortness of breath, nausea. And so you can see their progression without having to ask the person to say, for every time point, what did you have at that point? So it just gives you a little bit more context for entering the room the first time.
Great. Thank you so much, Josh. If you have more questions, again, please see him at his poster.
Thank you.
We are going to move to our final presenter for this session. Arden O'Donnell is going to present on her poster, Mindfulness and Self-Compassion, an Intervention for the Management of Neuropsychiatric Symptoms to Reduce Caregiver Stress.
Good morning. Okay. So yes, I'm a social worker working at the Center for Aging and Serious Illness at Mass General, and I really appreciate this opportunity. We actually have 2 posters here today that are showing the results of our open pilot, which is the second phase of an NIA-funded intervention that incorporates mindfulness and self-compassion skills to reduce caregiver stress caused by the challenging behaviors that arise from neuropsychiatric symptoms. Ooh, okay. I see what they're talking about. All right, so this intervention was developed because the challenging behaviors that arise from neuropsychiatric symptoms are actually one of the greatest sources of stress for caregivers. And despite this, there are really few interventions that provide the participants the combinations of skills that they need. So for instance, support groups don't really give behavior management intervention skills, and behavior management interventions don't provide the skills in emotion regulation or sort of to deal with some of the emotions that come up during these behaviors and that cause challenges and stress to caregivers. So our conceptual model is, you can see here, it's a combination of 4 different programs, which is DICE, as well as John Kabat-Zinn's mindfulness and, I'm so sorry, MBSR, so I can never remember that, mindfulness-based stress reduction, as well as Christine Neff's self-compassion. And that was used, these 3 were used to develop our conceptual framework, which is our mechanistic targets, which is one of our posters, as well as the skills and that we are using within the intervention. So the intervention is a 6-week virtual program that focuses on the psychoeducation and incorporates psychoeducation, as well as these mindfulness and self-compassion skills, as well as problem-solving discussions to help with these challenging behaviors. And in our discussions with caregivers in our first phase, they really emphasized that they really wanted skills that they could use during caregiving, so within the process of caregiving. So I wanted to give you all an example of the intervention, which I think will give you a sense of how we do this. So the first thing that we do is we introduce this stress spiral, and we ask caregivers to think of a challenging behavior that comes out that triggers them. And we also have a chart that shows common neuropsychiatric symptoms and behaviors associated with it. So, right, we're integrating that psychoeducation part into the work that they're doing here. And then they look at and use mindfulness to think about that situation, curiosity, and think about, what was I feeling in my body? What were the thoughts that I was having? How did I sort of respond in these situations? So, for example, a common challenging behavior associated with disinhibition is saying something embarrassing in public, right? So they imagine what happens when this person said something embarrassing in public. And then they go through and they think about all the different aspects. And then you'll be able to see that that's when we are within subsequent sessions. We then teach skills associated with these different, the mindfulness as well as self-compassion. So if we're going to be looking at intervention points. So as they feel this stress in their body, maybe this is a time to take a couple deep breaths to help them respond rather than react in that kind of a situation. Or if they're having certain thoughts, that would be a place that we could really intervene with self-compassion. So in this poster, we are looking at the exit interviews of 12 stressed caregivers that were a part of the exit interviews of our second phase. And we used rapid data analysis to be able to look at this, as well as thematic analysis, looking at sort of deductive and inductive analysis of this. So in terms of the perception of the content, as you'll see, that they really enjoyed and appreciated the stress spiral and understanding the triggers and thinking about that was a way that they could catch themselves. The other piece that they really appreciated was the self-compassion piece. And you can imagine one of the things that they were saying was stuff like, okay, like, what are the things I'm saying to myself, and how does that contribute to the stress spiral? With the idea of, if we can intervene before the spiral gets worse, if we can stop, then we might be able to make it so at least it stops the stress spiral, or then moves them up into what we consider the well-being spiral. And we also were able to gather information about our manual as well as the tools that were involved. Specifically, they appreciated the manual as well as the daily interventions, the daily emails that we sent to sort of remind them how to incorporate this within their own caregiving practice. So some of the feedback that we got that we then incorporated into our larger feasibility clinical trial was that some caregivers felt like that the content was a little bit too basic. And they thought that maybe this would be better for people earlier stages as they're just beginning to start deal with the behavioral symptoms, because by the time they got to be crisis, sometimes they would say something like, well, that deep breathing, that just went right out the window. I wasn't even able to deep breathe. I was in a crisis, right? So, right, sometimes you need more than deep breathing. But our argument is, and you should be breathing also, right? You should, let's not forget to that also. But the other thing that I think was really important, and as a therapist and a social worker, what surprised me a little bit was that when you teach mindfulness content, it actually does bring up emotions, right? As they began to slow down, they were then feeling these emotions. And so you can see this particular quote, but this participant said, I'm not completely sure that I was ready because it requires a degree of vulnerability that I wasn't really comfortable with or accessible. It was really accessible to me. So I think that's an important piece when we think about this. And the last thing that I wanted to say, and I hope that you'll come and ask me questions, or you can hear more about our intervention and we can talk more about the things that are on the poster, but this I thought was really good and particularly poignant for this conference. And caregivers really felt unsupported and really had a hope for more programs. And so I'll read this one that said, the most important part of this program is that it exists. Because truly, when your spouse or loved one gets a diagnosis of Alzheimer's, the medical community basically hands you some Aricept and says, good luck with this, right? And that just, to me, was sort of heartbreaking. And what I will say is that I've never been to this conference before, and I've been so impressed by not only the level of caring that this group comes with and your dedication. And I just hope that this quote sort of inspires you all, but also really helps you realize how much work you're doing. that is so appreciated, and do more. And so you can come see our posters, but the takeaways were that we did find that this is something that we think is really going to be helpful and has shown it within the mechanistic targets as well as other things that we think that this will be an intervention that really is helpful. You can come learn more and you can come find our posters. This is the team. Thank you. I'm happy to answer any questions.
We have time for one question if there's someone that has, yeah.
Thank you for this presentation and the focus on caregivers. I'm wondering if you could talk about the makeup of the group, whether you mostly had caregivers of people with a similar type of dementia, or was it across conditions? And then any diversity differences amongst caregivers that were part of it and how that showed up in the effectiveness.
That is a great question and probably longer than we have, but what I will say is we didn't. So in this group, they could be someone who was, you know, a daughter who was taking care of a parent or a spouse. They also because it was virtual, it's across the U.S. And so the diversity was not only across as much as we could, race and ethnicity as well as, but geographic areas. So what I will say is because this is so skills-based and manualized, that I think that piece was fine and it worked well. And you didn't need to. So some people, one group had people who had Lewy body, you know, had a loved one who had Lewy body and someone else was in Alzheimer's and they could be on different stages of disease. And so I actually think that the skills were really good in that way, and they got to hear about different aspects of different diseases. And one of the things about self-compassion is about realizing they're a part of the greater community and that you're not alone and that there are caregivers in other places that are suffering also or experiencing this. That's one of the pieces that you incorporate into Christine Neff's work. And I think that was really helpful that it was a diverse group within this. And also they weren't always thinking, well, my loved one, if I'm here now, my loved one is gonna have this, because we do a lot of psychoeducation about dementia being a neurodegenerative disease and that it's different in each person and everything like that. So I actually think that was helpful. Although I think that as we're heading into maybe doing a larger clinical trial, I think that's one thing we'll have to think about is, do we want to try to have caregivers that are all spouses or all parents or something like that? To be determined, I guess.
Great. Thank you so much, Arden.